welcome you all for this today's webinar of the reproductive freedom. We are talking about that empowering women through the kind of a fertility care. As you all know, doctors, I think Nova IVF is the fastest growing IVF chain, helping to realize the dream of a parenthood across the country. With 122 branches across the country, spread across 63 cities. So today on this webinar also, it is the kind of an evidence where we have an audience right from Kashmir to Kanyakumari, and also in the audience joining from an abroad, as we have a branches in Dhaka and the Bangladesh audience also. A warm welcome to all of you. Nova IVF, as you all know, that it has been known for its clinical excellence, embryology excellence, and the way the kind of an ethics and the transparency in terms of the practice. We are honored to have here today the kind of the moderators who have been very well known in the kind of an infertility space and who does not require kind of an introduction. A warm welcome to our Chief Clinical Mentor, Dr. Sonia Malik ma'am, and also the moderator, Dr. Jayesh Amin, our Clinical Director, and also the Nova IVF and Wings in Ahmedabad. So it is a great pleasure to welcome you all, and I'm sure that with this kind of eminent panelists also spread across the country in Nova IVF joining here, will share us with a lot of insights, and I'm sure that today we will have a lot of things to take home the message on this reproductive freedom. With this, I welcome once again, and over to you, ma'am, Dr. Sonia, ma'am. Please, you can welcome Dr. Jayesh and short introduction to the panelists.
Thank you very much. Thank you very much, Mr. Selvam. Good afternoon or good evening, early good evening to all of you. Welcome to this NOVA webinar across the country. As Mr. Selvam has already said, this is a national webinar which we are welcoming all our friends from across the country. And as he has mentioned, it is on reproductive freedom. You all know that now the ART services do not mean only infertility. We are extending it to beyond infertility. So even normal people can now avail of certain services which will help them to achieve their goal, whether it is fertility or infertility or whatever they want to do. So now there is a lot of change in ART services with which we want to achieve freedom for the women and the will to have a child at will. So therefore, we shall today be talking about whatever is currently available with all of us, and for which Nova has become one of the leaders. So I welcome my panelists for this wonderful webinar, and I have with me 6 great senior consultants of this Nova family. I start with Dr. Mahesh, who is also a strategic director. And he's based out of Bangalore. He heads a unit over there. Then we have Jasmine, who is our clinical director also, and based out of Chandigarh. She's one of the board members for the based out of Jalandhar. She's one of the clinical board members for Punjab Medical Council. We have Kalyani, who is in mid-India. She is, of course, in Indore, a senior head of the department and manages a center from Indore. She's been in Nova for a long time. We have Kritika from Chennai, again handling her own center, very senior consultant, doing excellent work, very sound in her knowledge and very good clinician. Rupali is again with us from Mumbai, and again here a very senior consultant doing excellent job at Mumbai. And then finally we have Indri, where I can't see her. Where is she? Is she here? And Indri, she is again from Calcutta. So you can see again a senior and very, very sound academician. We know that we have all of them coming from all parts of the country, and so you will have a flavor of entire India over here today with us in this webinar. So over to Dr. Jayesh, who is going to lead us through this webinar and take us through it.
So thank you, madam. And as we know that today we are going to complete around 78th independence India, and India is having freedom, which is 78th year we are celebrating tomorrow. It's not about that freedom. We are today all the fertility specialists, and we are talking about how in the infertility treatment that we are getting a freedom in the infertility treatment, and for the women by using this fertility treatment, how they got a freedom during this treatment. So let me share my slide regarding I think so. It's visible. Yes.
Yes.
So welcome all the fraternity friends, seniors, and my all Nova fertility doctors. Today, at the outset, as tomorrow we are going to complete of 78th year for freedom. We are talking about the reproductive freedom, choices, challenges, and the future. As we know that in the female, the biological clock, it is so sensitive. So I think so we have, everybody we know that the menarche is starting around today in today's era around 10 to 14 years of the adolescent's life. And I think so we know that the marriage age is around 18th year, and in ART Act, we can do IVF treatment around 21 year. They can proceed, they can go for to use the ART treatment. But as we also know that biological clock is around after in Indian women after 35 years or after 37 years, the chances of conceivement is become lesser. So they need to plan their pregnancy of the parenthood or motherhood between 21 to at least 37 years. We know that after 42 years, there are a lot of data which is saying like that the chances of euploid embryos are very less. And during this time period, it's all about the career. It's all about the nurturing the strong and supportive relationship. It's all about that financially and emotionally ready for a children. There's a lot of things that the women need to do in their life. So biological clock does not wait. And if biological clock does not wait, but if you are planning the pregnancy in the later half after 35 years, you do have a lot of problem. It may be a fertility declines with the age. You will end up with the decreased number of the healthy oocyte, and chances of healthy pregnancies are lesser, more pregnancy complications, more genetically abnormal baby, which going to be occur in the later part of the age. So how to preserve the female fertility? What freedom that the science will give to the today's era of the woman? What is the science behind it that we want to discuss? We know that the oocyte cryopreservations, it is which are the indications which were the oocyte cryopreservation, that for that we need to freeze the age. Can we freeze the age? Even they want to plan the pregnancy later. And for freezing the age, I think so we need to freeze the oocyte. We need to freeze the eggs. Why? Because of the career aspirations, maybe education goals, maybe financial security, maybe sometimes they are in the search of the right partner. Maybe there's sometimes that the sperms are not available in the infertility treatment. And yes, of course, the medical reasons that cancer patients in that conditions, cancer patients might be, it is today there, they are trying to remove the cancer from their body for the healthy life. But what about the happy life? Can you freeze your eggs and get a motherhood in the later part of the life? And that is why the oocyte cryopreservation is required. So the first human pregnancy from the previously cryopreserved oocyte, which was basically seen in 1986, the first cryopreserved. So it's a science which was already in the western part of the world, which was already published in 1986, the first cryopreserved. But then up to then it is considered as an experimental therapy. And after 2013, American Society of Reproductive Medicine announced that. And that's why if you see the registry of the American Society of Reproductive Medicines, that in 2009, the 500 people utilized the oocyte cryopreservations. But in 2021, if you see 24,558 women went for oocyte cryopreservation. So day by day, women are doing a oocyte cryopreservation for the various causes will be there. So this all because we need to use all the treatment. We know that yes, we are having a treatment. It's so difficult for women to understand because of the cost of this treatment. So today we will discuss about what are the hindrance, what are the social isolation, what are the financial burden for doing this oocyte freezing will be there. So let's start something to know about more reproductive autonomy for a female. Let's start some of the case-based discussions specifically for the oocyte cryopreservations or the freedom for the woman in this fertility treatment. So my first case, which I want to discuss to Dr. Dr. Kaur is there. Dr. Kaur?
Yes.
Yes, Dr. Jasmine.
Good evening, sir. Yes.
The first case is 32 years female. She's single. Her AMH is 1.8 nanogram per milliliter, and her AFC is 10. Wants to delay the childbearing for 5 to 6 years. So my question to you that what success? How can you counsel the patients? What are your counseling in your cabin when a female who is she just delaying the childbearing age and her AMH is like this? And how can you counsel? What are the number of eggs related to efficiency of the output of the pregnancy related to number of the eggs?
Sir, first of all, I think she is taking a right decision by doing some social egg freezing. That would be the call. Because at 32, she's not planning for another 5 to 6 years. So she will cross 35 and she will enter into advanced maternal age, which will bring its own complications. So the social oocyte freezing, it has to be explained and counseled to the patient from the beginning. We have to explain the whole of IVF to her and what all she has to go through while she is going into IVF. And we stop at that step of retrieving the oocytes. Since she has a good AMH now and her AFC is 10, we can hope for good 8 to 10 oocytes in the first go. And as per the whole process, we have to explain to her that the thawing is 80 to 90% retrieval. So let us suppose we freeze about 9 to 10 M2s for her in the first stimulation which she gets. The thawing will give rise to 8 to 9 M2s will be retrieved, maybe 10 out of 10. And ICSI in these oocytes, whenever in her life she wants to conceive by IVF, would again lead to good number of blasts, like about maybe 50% blast rate is there from the number of oocytes which we thaw. So an ideal number, what I would say is around 20. With 20 oocytes, there is almost 70% chance of live birth rate as per what is quoted. But the studies are very less. Many of the women who have undergone oocyte cryopreservation have not used them. We can put it like that. And so the prediction goes like that, about with 20 oocytes, she will have about 70% chance. So younger, the better. More the oocytes, more are her chances.
So exactly, Jasmine, you want to say something about the number of the oocyte. I think so. Anybody can say some that if how you are going to counsel the female regarding, can you counsel regarding that what are the parts which involved in the oocyte cryopreservation process? How can you counsel regarding the process also? Are you interested, Jasmine? Jasmine, how you
Yes.
can counsel the patients regarding the process?
Uh, Regarding the process, we will guide her through the whole IVF process, that she will require a stimulation of almost 9 to 10 days, and then ovum pickup under some sedation or short general anesthesia. And those are the oocytes which we retrieve. The M2s will be cryopreserved, and then we can walk her through the thawing and ICSI. Once she has chosen a partner, she has chosen a sperm.
So fine. Dr. Jasmine explained that what are the number of the oocyte, and there are some few studies are already I'm showing that at which number of the oocyte, that 20 mature oocytes. So there are some study that if you have a 20 mature oocytes, then 90% one live birth rate will be there. But if you want a two live birth, 66% two live birth rate, if you are up to 34 years, if you have a 20 mature oocyte will be there. And this is the graph which shows that how the number of the oocyte. So more the number of the oocyte, that she rightly said, the more the number of the oocyte, chances of live birth is higher, and you need to show all the data to the patient that how many number is required. And
Yes.
by that also you can counsel that if the one pickup is going to cover around 8 to 10 oocytes, and somebody those who want more number of the pickups in the different age group, that then they can freeze more number of the eggs, specifically when the age is higher. So these are
Yes.
certain data that 39% final live birth rate, which was reportable compared to the age matured outcome will be there. So the largest US report in warming outcome. So the important thing is that we need to also counsel regarding that when we warm, the survival rate is 100%, but maybe possible because of the different age involvement, the live birth rate might be reduced as far as concerned we freeze the eggs.
Yes.
So oocyte survival after vitrification is generally very high, but cumulative live birth rate in patients varies from 26 to 39%. It is because of the number of the patient is heterogeneously involved in the different age group is there. So take home message for this question is, for this patient, set an initial target around 10 to 12 M2 now. Discuss the options of a second cycle if first yield less than 10 M2, and revisit in 1 to 2 years if still undecided will be that patient. So advantage and disadvantage of oocyte cryopreservations: that avoid ethical and legal issues related to embryo creations. Individual ownership: oocyte are the sole property of the one person that we need to counsel her. And further, future partner procreations allows procreations with a future partner. Cost effectiveness: generally less expensive than the embryo cryopreservations, and survival rate: oocytes have a lower survival rate compared to the embryos. That counseling that we need to do. So planned only the fact that what we are just going to inform you today, there's only 38% of the patients had returned for a warming. This is what the latest data, 10 to 15 years follow-up, return rate, and the cycle outcomes when we do have a freeze of the eggs. But the problem is now the awareness is increasing, and more the female is going to be freeze the eggs. And I think so in the future this data will change. More and more female will come for the returning for the getting a babies in the future. That what we can explain by this all the data which was presented. So egg freezing, just a choice to postpone motherhood or unnecessary also. And some things, the egg freezing can be advised to the patient as far as cancer, endometriosis, genetic disorders, and early menopause. We can advise. This is the case. Second case, the stage 3 endometriosis patients, 29-year bilateral endometrioma, having no kids, moderate pain, and surgeon plans cystectomy. Too much concerned about fertility. So my question to Dr. Mahesh Koregal first: what is your advice in this group of the patient? Because in and out, there are a lot of female those who are advised for the laparoscopic surgery in endometriosis. What is your take home and how you counsel the patient?
Thank you, Dr. Jayesh. This is a very important question. A lot of people ask this question, whether removing this endometrium is necessary. My laparoscopic surgeon has advised. I would like to stress again that removing endometrioma might damage the further remaining ovarian reserve. So that is the reason we do not prefer the endometrioma surgery as a first option, especially those people who are trying to conceive. In case of those patients, there are only two indications which is advisable or advisable for doing a surgery. That is severe pain, unbearable pain affecting the life. Yes. Number two, if the endometrium is so huge that you are not able to access it. So it is always advisable for the lady to undergo the oocyte aspiration, and if they're married, create an embryo. If unmarried, at least freeze the oocyte before they go ahead with any sort of surgical intervention, because there are a lot of long advices they get. And we see the other end of the spectrum. We see those people who got operated and their ovarian reserve itself is gone, hardly any AMH is remaining. So there are multiple studies which are showing that the ovarian reserve AMH is higher before surgery, but after surgery it has fallen very much. So what it means to say is, operating is more damaging than fertility point of view, wherein the oocyte can be aspirated.
So Dr. Kalyani, would you like to give some more message? Because in and out, I would like to more pinpoint this question, that in and out, being a fertility specialist, you will observe that more patients are having a surgery. So what about if there is no pain? What is your advice to this type of endometriosis patients, and how you are
Absolutely
dealing with
not
this
to
patient?
operate. My sincere advice is absolutely not to operate. There are a lot of new laparoscopic surgeons doing a lot of heroic surgeries, which is absolutely not required, because number one, this is not a permanent solution. Again, after a couple of years, you will see that endometrium has come with more vengeance. It has come more severely. There is a pelvic adhesions. There is almost a plastered pelvis. What are you going to do then? So again, fertility is already low. Inside the tubo-ovarian anatomy is spoiled because there is adhesions. So these patients anyway cannot conceive. The point of surgery, if fertility, is not going to be of much benefit. So my sincere advice is not to think much in terms of laparoscopic approach, because yes, there are a lot of youngsters we see doing a lot of surgeries, and the people think that's the way to go. But then yes, surgery for endometrioma is a last indication if fertility is the criteria. So if there is persistent pain or very large endometrioma or recurrent endometrioma with abscess formation, or if there is a rupture or torsion in them, yes, you can think of surgery. But otherwise, routinely, as soon as you see endometrium on ultrasound, you call up your friend who is doing a laparoscopy and call him to operate is not justified, because they are going to end up with a very low egg reserve, and maybe sometimes so low they will end up so that they will not have any chance of their own eggs doing IVF. They may have to go for a donor egg because of such a destruction of ovarian cortex. So that should be taken into consideration.
Dr. Kalyani, are you there?
Yes, sir, I'm here. So I think Dr. Mahesh has answered most of the things to it,
Now
and I
let
do
me tell
agree
you
to
that
it.
when you are counseling your patients for IVF, if there is a huge endometrium of around 6 centimeters, would you
Yes.
encounter in your day-to-day practice that sometimes you need to do surgery? That which are the cases where you need to do surgery? Apart from that, Dr. Mahesh Koregal says that yes, we will definitely don't do surgery. But sir, there are certain cases where maybe surgery or maybe aspiration might be required in your practice
Benefit,
or
yeah.
not?
Yes, so there are certain cases where, we have to justify doing the surgery before the IVF. So normally what we look into is only two indications. One is if I'm going to do the egg retrieval and if I don't have the space or if I don't have the access going towards the, the healthy follicles that I need to aspirate, in those cases, I would prefer doing the surgery first, mobilizing the ovaries and then coming back and doing the retrieval. But even if I have got one ovary which is not fixated, it is all healthy, probably I'll do first the oocyte retrieval and then move towards the second cycle before for the surgery, followed by the second cycle and doing the embryo freezing for them. But yes, that is one of the indication and the most important indication before an IVF, in case if we need the surgeries only for the accessibility of the healthy follicles to be aspirated and not accidentally puncturing those endometriomas and causing later on the abscess or spillage of the endometriotic fluid in the pelvis. So whenever we find that the access, the anatomy is distorted and it's very difficult for us to aspirate, we will go ahead with the surgery. The second is in case we already have done the aspiration, everything, we have the embryos frozen, but still the patient is not comfortable. The quality of the life is very, bad for the patient, where they see that, I can't bear the pain for that. Probably I'll do again the retrieval, do the freezing, do the surgery, and then do the embryo transfer for them, so that they get that good quality life as well when they want to plan taking the embryo transfer.
So I think so both consultants are in the favor of not to operate, freeze first and operate later. That what they a clear-cut message. And I think so Dr. Kalyani will tomorrow on 15th August, he will release one more campaign, and that is called #Don't Touch the Ovary. So this is what the message that we want to give to all the population, that there is no need of unnecessary surgery, specifically on the genital tract in today's era of the fertility. We want to freeze first and then we can go ahead. This is the message we want to give to all the populations. Now, this is the case 3, which I think so in the freezing, we know that the treatment of the cancers in today's era and where the survival rate is become higher and higher. Sometimes we know that even the grade 3, there is immunotherapy. The patient, those who are having a grade 3 lung cancer, I think so example is Sanjay Dutt is there. And there are a lot of other intestinal cancer where identifying by the certain score system and giving them immunotherapy will cure their cancer. So it's not about the healthy life. It's all about the happy life for the future. It's all about the family planning. And specifically in the female, this is the case that I'm sharing, that in the breast cancer, ER positive, and she is 34 years, ER/PR positive, and her to planned ACT chemotherapy and wants fertility preservation. Now she wants fertility preservations. Now, can we do stimulation, because she don't have a time? So now the message I want to give to all people, that in a short time of the period, or can we start random stimulation in this group of the patients? And this question to Dr. Andre Sanyal. Can you just give a light on that? What about the role of random, and you can put the stimulation in a shorter time, specifically in breast cancer patients, and how can you counsel this patient? Dr. Andre.
Good evening, Dr. Jayesh. Yeah, actually, first and foremost, like for this patient, as you already mentioned, time is of essence. So, but still, before starting anything, I would still want to have a clearance from the oncologist before starting her off with treatment. And as we all know nowadays, there were days when we used to stimulate patients only between cycle days 2 to 5, but assuming that there was a single wave in the cycle. But now, as we know that there are multiple waves in a single cycle, so yes, we can start her off with random stimulation also whenever she comes. So we would probably need 10-12 days in hand. That is all. And we would counsel the patient likewise that whenever she comes, we will start her off with stimulation, 9-10 days of stimulation, followed by egg collection and egg freezing.
Yes. And I think so. What are the Dr. Rupali Thambe, that what in your stimulations, would you like to add some other treatment add on to reduce the side effect of the stimulation? Because she might have, if you are stimulate the ovary, then estrogen will go very higher. So would you like to co-administrated the other all oral drug or like that? Any evidence will be there specifically in this case?
Yes, sir. Good evening, sir. With breast cancer, and we don't want too much of estrogen exposure now in this case. Definitely, I would like to add on something like tamoxifen, which has got a anti-estrogenic effect on other tissues, or letrozole. I would like to add on in such case.
So if the patient don't have a time, suppose it's only 7 days, then or pre-menarche, then what you can offer it to them in this group of the patient when stimulation is not possible because they don't have a time, they are only have a less than 7 days, and if she is a pre-menarche in that conditions, what is your counseling and how can you counsel the patient, what you perform?
Sir, in this case, we can go ahead with ovarian tissue cryopreservation, and later on we can, transfer these after her completion of treatment. We can transfer this ovarian cryopreserved tissue in her ovary, and almost 20 to 30% live birth rate has been reported with this modality. If she's too short of time, then GnRH agonist also we can suppress. Her gonadal suppression can be achieved. In vitro maturation also is one emerging method wherein some live births have been noted, but very few labs has that kind of expertise for in vitro maturation.
So rightly said by Dr. Andre and Dr. Rupali that the message is very clear. It's a freedom that you can freeze your eggs. And even though no worry about that the time is less, if it is more than 12 to 20 days, then in that conditions, you can just have a oncofertility communications. The oncologists do counsel the patient, send them to fertility specialist. And in that condition also, sometimes there are so many countries where they are sending the counselor to the patient house because patient is psychologically so depressed. So they counsel at home and prepare them and saying like that this procedure is required only shorter days, anytime we can start because they are in hurry to proceed for any chemotherapy or surgery, especially patients also and sometimes surgeon also. So in that condition, you can complete your surgery by random start stimulation, by co-administration of the letrozole, which is reducing the estrogen level and preventing the side effect will be there. And these are the guidelines what we can observe that how we can go and explain and counsel the patient specifically in the oocyte cryopreservations will be there. So egg freezing, Dr. Rupali Kambe, do you encounter certain problems where the cost is an issue? Then how can you counsel the patient in this group of the patient? Suppose they are asking regarding, because cost is always around 1.2 to 2.5 lakh rupees in India where the egg freezing. Then how can you counsel this group of the patient?
Sir, if we counsel the patient about the importance of biological clock, definitely the going ahead and see, our primary focus is to give them a biological child. In that case, suppose she doesn't freeze her eggs in time, over a period of time with her lower AMH, she may have to undergo multiple cycles of stimulation, or she may have to go for third party like donor egg. In that case, if we compare, this is quite cost effective. We are going to get younger oocytes, we are going to get more number of oocytes, and she may not require multiple stimulations. In single stimulation also, we can get enough number of good quality and good number of oocytes. So this is quite cost effective when we see a bigger picture.
Yes, you are absolutely right. In Israel and certain country, we are expecting that India also move on that. They are providing egg freezing. Certain cycles are free also, and that's again, it's all about the country concern. But I think so. We people do have a certain EMI options, and then we can explain the patient that EMI options, so they will go ahead because they are already burdened by the lot of the oncology treatment will be there. And yes, you need to explain that you can get your biological child in the future, and effect of the surgery that will going to reduce your chance to get your biological child. So that is we are explaining in and out. This is the case for 31-year male. So we already discussed that how female is getting a freedom by freezing the eggs. It's not only the social egg freezing. It's all about the when you are having endometriosis. It's all about when you are suffering from any cancer. In that all condition, freezing your oocyte and planning the pregnancy later, it is giving a fertility freedom. Same like that in the male part, a 31-year male with a CA colon, now married, no children, well educated, stage 3 sigmoid colon cancer, and starting Folfox plus cetuximab in 3 weeks. So chemotherapy, baseline semen parameters are normal, concerned about the gonotoxic effect, and his the oncologist sent to the fertility specialist that what we can do. So my question is, what is your advice as a clinician, Dr. J. Kirtika Devi? That I think so. We do have a lot of incidence of the colon cancer and everything nowadays. So what message you want to give for a male for a fertility on a fertility freedom, Dr. Kritika?
Yeah, good evening, one and all. So considering preserving fertility in male, it's actually much easier compared to a female. So we should never miss the opportunity of freezing a semen sample. So that is the most important thing. And generally for male, since the time is short, there is no need to wait for that classic abstinence period. We can even collect the sample every day, just with a shorter abstinence period also, we can collect the sample. That is the second point. And another thing is, routinely, it is better that we collect at least 2 to 3 ejaculates as a backup. If the sperm count is good and if the volume of the semen is also good, then from one semen collection, we can allocate it into 2 vials and freeze it as 2 samples. So that is another option that we have.
If there is a no sperm in the semen, then what exactly? If patient is having a no sperm in the semen, or is not able to ejaculate by the masturbation, what the alternative treatment would you like to advise to that patient?
So we should find out what is the cause. If it is a psychological fear during the malignancy, then we can give them some drugs like sildenafil, oral drug.
Can you provide as a fertility specialist some other treatment that you can collect the semen from the testes or like that? In patient is non-obstructive, that he's not having azoospermia, but he's not able to give a semen because of some erectile dysfunction at that time, or maybe not able to masturbate in that conditions. Would you like to provide some other alternative surgical treatment to freeze his sperm, or would you like to say no?
I would like to preserve. Yeah.
We
There are
can go
other
by.
simple options. Now, some men may be comfortable collecting from the home. So we can give that home collection option, or we can allow the female partner to be with him if it is a psychological anxiety. Then there are sterile condoms which are available, which he can try. Then we can try with medical treatment like sildenafil. Vibrators are there. And as a last resort, we can go for testicular sperm aspiration.
That's why I want, you had already advised that these are the alternative treatments sometimes you need to use in your clinical practice. And these are the things that by that we can freeze the eggs, or I think so in India still we consider that tissue cryopreservation of the testes is still, we don't have that much of use experience. It is still experimental, but if there are in the part of the world, I think so they are also overcoming with the tissue cryopreservation of the testes. In the especially prepubertal male, they are freezing the tissues also. So this is all about that we can provide the freedom, I think so. Would you like to advise Kritika that like female is always saying like that my biological clock will run away at around 40 years. So is it something in for male also, they do have a certain awareness for the freezing for their sperm, because at the end of the day, both are humans. Would you like to say some comments on that, that sperm freezing might be important for the autonomy? Maybe they are married and they want, maybe because in this real world, what happened in the future, maybe some divorce and maybe he will end up with a certain problem in the sperm. So would you like to give some comments on that, that just like a female, male should going to freeze the semen for a certain indications or like that?
Yeah, thank you for this question, because there is a very common myth among public that men are immortal and their sperms are immortal. So that is a myth, and a lot of scientific studies have proven that after 40 years, there is a decline in the sperm parameters also. The morphology, the motility, and even the count, there can be a negative impairment, especially the DNA fragmentation index also can be higher. So it is important for the man also to protect his fertility when he crosses 40 plus.
And even advanced paternal age, if they want to plan in the future, maybe by certain conditions, then there is a high DNA fragmentations and chances of a lot of genetic problem will be there. So sperm freezing might be one of the options that's really in the discussions, and it will give the freedom to man as and also the man, and also what we are thinking about the freedom for the female when we are doing the oocyte freezing will be there. So this is what the take-home message are important, that we can have a 1 to 2 sample, we can have a semen freezing. And now I want to, whatever the interaction with the audience that we will take later on, I will like to request Dr. Sonia Malik that he will take over something about the what she want to discuss regarding on the day of freedom in fertility freedom.
Thank you, Jayesh. That was excellent. And I think the audience would have benefited a lot by what has been discussed, and very, very illicit, very wonderfully explained every point. So now let us go to the little more controversial part of it, or maybe the essential part of it, I would say. That is the essentiality, as we would say, in our in the term. So let me just share my screen now with all of you, and then we go on to the next part of this webinar. Yeah. So here we are. Whatever we may say about freedom, whatever, we all know that in any society, we are ruled by certain rules and regulations, and a society is always made when we follow those rules. If we don't follow the rules, it is jungle rule. So therefore, rules and acts have been laid down for all of us in order to behave in a certain manner. And now we know that in ART, there are 3 kinds of acts that have been passed which dictate us. And therefore, whatever we try to achieve in order to give freedom to our women, we are dictated by these acts. And therefore, let us take a look at this and try and fit in what Jayesh has just told us, and see whether we can rightfully do all that has been proposed over here, and whether we can really practice ART the way we wish to. So I will be taking not the PCPNDT Act, not the MTP Act, only the ART Act, because we are talking of fertility and preservation of fertility, to be more precise. We all know that these licenses are essential when we want to start an ART center. However, having these licenses also, we need to remain within the rules. So here I've particularly directed questions at my panelists, and this one is for Dr. Mahesh. She's a 49-year-old patient, and she comes to your clinic with the complaint of infertility, and she's going to be 50 years in the next 2 months. But she has embryos frozen with us since 3 years, and for some reason she chose not to come to us. Now, how are you going to manage her? What does the law say? What is the current scenario? And what are you going to tell this patient now? Are you going to start investigating her, treating her? What is the caution that you're going to maintain with this woman? Dr. Mahesh?
Thank you, madam. This is a very important question because some of the even doctors are also not aware exactly what does the ART Act says about the age limit. It's very clear that we cannot do a couple treatment if the woman's age, the wife's age is above 50 years or a man's age is above 55 years. That is, woman has to be between 21 to 50 or man has to be between 21 to 55. Either of them, if they have crossed that particular age, you cannot offer fertility treatment. Even the embryos are frozen with you. Even if in the past they are frozen with you for a future treatment or for a second baby, no matter what, if one of them have crossed this stage, you cannot do. But coming to this particular scenario wherein the lady is 49 years already, so only 2 months are remaining. Yes, you can undergo. You can start her with a frozen embryo transfer cycle and finish before she turns 50. That is option number one. Option number two, if there is any medical condition for which we cannot transfer or we need to treat something, then there is a special permission she has to take from the court, and she has to take a special permission if she needs to undergo embryo transfer once she turns 50 years of age. That is very clear.
So unlike the adoption law, wherein you calculate the joint age of the couple, that means husband and wife together should not be more than 100, 102. Here it is separate. This is a very important point that Dr. Mahesh has made. Wife separately and husband separately. So if you have a husband who is 57 years and a wife is 36, you still cannot do it. Right, Dr. Mahesh? And vice versa.
True.
Very, very clear. So, Dr. Jaspreet, this marital status is indicated in the ART Act, and they say that it can only be done if the couple is legally married or she's a single woman. Live-in relationships and same-sex couples are not allowed. Now, how do you establish, and so for that matter, even single men are not allowed. For that matter, then, how are you going to establish the marital status of this couple when she comes to you?
When a
How do
couple
they
walks
complete?
in, we do ask for an age proof, and that ID should be bearing something like wife of so and so, and that will establish that the couple is married. It can be an Aadhaar card, a PAN card, a license, or even a passport if they can give it to us. And if these proofs do not say the relationship, then we do need a marriage certificate. And to be on the safe side, we are asking almost everybody to submit a marriage certificate with us.
Okay, so
So that,
therefore, very, very important point. You cannot bypass the law. The patient has to be married. Many couples will come to you with the live-in relationships. They are all now aware of this act, and they would pretend to be married. They would not admit that they are married. Please don't be let in by that, and you have to establish their relationship before you start doing any kind of a treatment for that. And that is very important. So again, like I said, single man and LGBT are not allowed. We have to complete the proper consents for these patients. Data entry has to be done. And storage of gametes and embryos is not for more than 10 years. We all know that. However, this is a very important point. We are quickly going to run through this act because we are finishing our time and we have to take questions as well. So what are the mandatory requirements in order to conduct these cycles if they are a donor cycle now? Suppose the woman is not capable of having it herself, then what about donor cycles? What are the mandatory requirements for that, Jasmine?
the most important thing, ma'am, would be that all the donors, egg or sperm donor, has to be from an ART bank. A direct induction cannot happen. And now the act allows a known donor So even if the couple is bringing their own donor, they have to be registered with the ART bank before we start anything by the way of treatment. And there is an age limit for treatment. There is a definite age limit for an oocyte donor and a sperm donor as well. So 23 to 35 would be the age when you are selecting an oocyte donor. For a sperm donor, it can be 21 to 55.
Yeah. So again, I think it's very clear, but you can see over here that the age of the donor is much less than what is written for the recipient, and we know why. We know that the fertility falls after that age, and hence it is reduced. For the male, it is still 55 years, which I suppose will be changed after a couple of years when they find that 55-year-old men do not produce very good sperms. But as of now, we have this, and we have to stick to this. So again, the marital status of the recipient is very, very important. Here, is it married or a single woman? Who is allowed? Again, it is both of them who can go through this kind of a cycle. And therefore, we have to be very particular about this. What is happening? Yeah. So, Dr. Rupali, this one is for you. Sorry, where is it? What if you have to give a donor to this couple? One donor per couple once in a lifetime is what is said. Rupali, can you say this? Can be a known or an unknown, but has to be routed through the act, through the bank. A donor embryo. What would you say about a donor embryo, Rupali? Do you think? First of all, let me apologize to Rupali. She is not in Mumbai, she's in Pune. And I sincerely apologize because I mentioned that she's a senior consultant at Mumbai, but she's at Pune. Donor embryo, what would you say? Would you advise a donor embryo? And how would you find this donor embryo? How are you going to give this donor embryo to the patient if
Yes, ma'am.
he requires a donor embryo?
Yeah, good evening, ma'am. Ma'am, yes, the donor gametes are allowed, like sperm donor and egg donor is definitely allowed. So a donor embryo cycle also can be carried out. Just that the donor has to, donate to one couple once in lifetime. And these gametes, as you said, can be stored as of now, as per present law, maximum for 10 years. And since the donor egg involves a surgical procedure, it does involve some health risk and some complications. Affidavit has to be made. Then, as Jasmine madam said, the altruistic donor is allowed, but we have to route this donor through ART bank. You directly cannot recruit them. And ma'am, it cannot be, the donation cannot be done on financial grounds. Like there cannot be a compensation to the donor. Of course, ART bank can, pay them for the loss of wages and loss of work, or for their transportation, all these things, ma'am.
Let me put it to you another way. There is a couple whose brother has undergone an IVF cycle with us, and we have his embryos frozen with us. Their embryos, that couple's embryos frozen. Now the brother, this present patient which you have over here, this couple is wanting to take the donor embryos of their brother. Can you give the donor embryos of one who is already stored with us to another?
Ma'am, to my
Can they donate?
no, madam, to my knowledge, this cannot be done.
Yeah.
Like you cannot give the gametes of one couple to the other couple, ma'am.
Correct. So essentially now what we have to understand is that if we are going to do a donor embryo, it is not mentioned anywhere, but however, we can craft a donor embryo for a couple, specifically for that couple, taking a new donor egg, new donor female, and a male donor, making the taking the eggs out of that one and taking the sperm. So this embryo which will be found will belong to no one except that particular couple. So that is what the difference is. Earlier, we used to give the surplus embryos to people by asking them to donate, but now we cannot do that. Am I right, all of you? Is there any difference of opinion?
Yes, absolutely.
No, I think absolutely correct, ma'am.
Okay.
Ma'am,
Sorry, yes, Jasmine.
Ma'am, the ambiguity of the situation is that these embryos were already made and therefore they were made for that particular couple. But
Yes.
if this couple wants to do a donor embryo with them, now known donor egg and known donor sperm is allowed. First,
Correct.
we will have to register them in the bank
Uh-huh.
as donors,
Uh-huh.
formulate a new set of embryos which will be now donor embryos for this couple. In case
Absolutely.
they are interested.
Yes,
Yes.
yes, that
Yes.
is possible. You can form a new set of embryos for them, but that particular one which was formed for them cannot be passed on to their
Yes, ma'am.
relatives.
That's the
That
law.
is for sure. Okay. So this is what Rupali has already told us. These are the things that we need to do. Affidavit has to be signed, and insurance cover is required, which is not required for the male because it's not under anesthesia. So basically, direct compensation. What is the status of a widow now? Kalyani, what is the status of a widow in the act? She's also
So,
single. Is she allowed IVF?
yes.
Okay.
So, ma'am, actually, there's no particularly return for the divorce or the widow, but it is to be assumed that she is a single too. And according to the ART law, a single woman can undergo an IVF cycle by taking the donor sperm. So yes, she should be allowed to undergo an IVF cycle according to the act. So I don't see that, she cannot undergo IVF or she cannot bear child according to the law. Yes, a single woman is allowed to do it, and if she can produce the death certificate, she automatically becomes a single woman.
Suppose she has a live-in relationship with a man now.
So, ma'am, again, then she can
There's a
take
ambiguity again.
the sperm, but she has to again go through the ART bank. The donor sperm, the sperm from the partner has to be routed through the ART bank and to be sent to the IVF clinic.
Okay, so basically she is to be taken as single,
Single,
although
yes,
it's not
single.
mentioned in the ART bank. It is not written. The status of a widow is not mentioned. It is specifically mentioned in the Surrogacy Act, but not in the ART Act. However, we can presume that she is single and therefore take it. It is essentially very important if there is a very young girl who's lost her husband and then she wants to have a child. So now this second question over here, if a couple has stored their embryos and the husband dies, is the widow allowed to get an FET done?
So when we do the freezing of the embryos, we do have the consent wherein it's mentioned that, if something happens to the husband, is the embryo to be donated to the wife or whether it has to be discarded. That means it has to be perished. So if it was given the consent by the husband when he was leaving that it has to be given to the wife, then yes, she can take that embryo and do the embryo transfer. But if there was no consent and it was written that no, in case of he dies and it needs to be discarded, then we cannot do the transfer.
Okay. Anybody differing in this? Okay. All right. So if a cancer patient has stored her embryos with you, Kalyani, can the embryos be used by the husband in the event of her death?
Again, and same. At the time of the freezing, what she has signed, according to that, the embryos can be given back to the husband. If she has said that in case of a death, the embryos can be used by the husband, then in that case, we can go ahead and give that embryos to the husband.
There is a slight catch in this because you will need a surrogate.
Yeah.
You will also need a surrogate. So is a single man allowed surrogacy? As we
So,
said,
ma'am, there are so there are 2 points to it, ma'am. If he is a single man and now he wants to take those embryos and put into the surrogate and, have the genetic child of a lost wife, it is not allowed because in India, according to the act, a single man cannot, undergo the surrogacy. The second is in case if he gets remarried and has a wife. So again, it's an ambiguity. We don't know about it, how to be used. But yes, because it's mentioned in the consent that the embryos can be used by the husband, probably after, taking the proper consents and everything, I think we can go ahead and do the transfer in that case.
But Kalyani, would you also want to take a legal opinion on this to be very
Of
sure
course.
what you are
Of course,
doing?
ma'am. Like I said, after taking all the consents, after taking all the legal advisory, then only we'll be able to get, and probably an affidavit declaring that, how it is going to be going ahead.
Yeah. So essentially, the message to all of you is, whoever is here with us in this webinar, is that there is a lot of ambiguity in what the Act is writing. But definitely, you can go and do something like what Kalyani is saying, and always take a legal opinion on what is right and what is wrong, because basically tomorrow you may be held responsible for something which you didn't intend to do. Hence, always take the opinion of a legal advisor and then go ahead with it, because as such, what she's mentioning is correct. The patients have rights to do that. So now, Anjali, Sanyal, according to the NMC, we are talking about teleconsults now. How much is allowed to us about doing consultation over the phone? This is a slightly different question. And a patient wants to come and freeze her eggs from the US, and she wants a consultation on the phone. Is she allowed? Are you allowed to give her?
So, ma'am, like you mentioned, if the patient is from abroad, international teleconsultation is actually not allowed. But within the country, we can do teleconsultations in the sense we can probably take the history and give the advice and counseling to the patient, but we cannot issue prescriptions on teleconsultation.
So is that also applicable for India, or is it applicable only for abroad? Prescriptions can
No,
be
for
sent.
abroad, we definitely cannot do.
Yeah.
Within the country, we can definitely consult and counsel a patient. And we, giving prescriptions, we usually avoid. Most of the times, we would ask the patient to come over and see the patient for ourselves and then only prescribe medicines. Until and unless it is something like folic acid and this, that.
Yeah. So very well said, doctor, because basically this is something that we do very commonly now. Ever since COVID, we've got used to the internet, and we are forever on the internet trying to do as quickly as possible whatever is asked of us. But remember, teleconsultation to international patients is not permitted under the National Medical Council rules, and therefore be very vigilant. You can only tell them, okay, you have to come over, even though it means even though it means 2 visits for them, and they have to come and make that visit, set everything with us, plan their entire treatment, and then go back and come again if need be, or they can come once and get it done themselves. But please do not fall into this trap of sending prescriptions to them, because this is not allowed. And what about, now let us, coming to the end of it, nearly I have only one doctor left with me. So let me just ask her, Kritika, we were talking of reproductive freedom in the donors and surrogates. Now, third party is altruistic. Once in a lifetime donation is also a rule. And then we are asked to retrieve only 7 oocytes per donor. We are not allowed more than that. The recipient gets only 7 oocytes per, after spending such a lot of money. And then the major thing is that there is a restriction on having a second child in surrogacy when the first child has been born through surrogacy. All this does not lead to reproductive freedom. And if we look at the pros and cons of altruistic surrogacy, which we are now saying, the cost, the familiarity, and accessibility are the pros. And the cons are that sometimes it can lead to strained relationships, because a sister-in-law may be asked to become a surrogate for her own sister-in-law. There are less safeguards, and of course, the costs may be hidden, but they are always there. Whenever there is altruistic surrogacy, there may be hidden costs and under the table exchange of money. So, but all this has been done to decrease the exploitation for the surrogate. Will you explain it more in a much more elaborate fashion as to why you think the government thought of this, and do you think it is correct? Kalyani, sorry, Kritika.
Yes, ma'am. I'm very much for this regulation by the government, because there was uncontrolled usage of surrogacy for luxurious reasons. Normal, healthy women, if they have money, they could just go for a surrogate. So poverty was used as a method for luring surrogates. So I'm totally for this rule. And coming to the restriction on the number of eggs that we can get, the rule of 7, we all know practically it is not possible to restrict to 7. But I guess the underlying idea is avoid overstimulation, avoid the risk of OHSS for the donor. So that is the basic point by the government to us. And earlier, when we used to give the excess embryos to 2 people, 2 recipients, probably in the long run, there could be a interbreeding of individuals whom we will never know. So that is something where here there is a restriction of 1 donor to 1 recipient will cut down on that. So I'm totally for it. And the next question of the second child, I feel surrogacy is a big burden for a woman to go through. So giving her at least the basic luxury of having 1 child should be okay to minimize surrogacy being commercialized.
Yeah, so essentially you are for it, and you
Yes.
defend it in because you've given very valid reasons as to why you think the government thought of all this and tried to restrict us in order to protect the interest of both the mother as well as the recipient, the surrogate mother and the recipient, and also the donor and the recipient. So therefore, safety for all women is the mantra, and therefore we have to abide by these rules. So coming now to the last bit of my take-home messages, please respect the law, please abide by the law. Do no harm to your patient and do not let her harm the other woman if it is a third party. That is something this we have sworn that we are not going to harm our patients. Therefore, remember this when you are dealing with any patient. Don't overstimulate them, whether it is for fertility preservation or whether it is a donor whom you are going to use. Don't overstimulate. Help all patients to achieve, all women to achieve reproductive freedom through this amazing science where we assist them in reproduction. So therefore, the idea is remain within the law, be good children, be good women yourself in order to treat women well. So that is our mantra to you today. Thank you very much for all of you. Now we come to the questions. I think I will have to stop sharing my slide and then we take the questions that are here with us in the, yeah, we have some questions here. 1 minute. Dr. Jayesh, will you take the questions, please? 1 minute. No, we are here. Not in the chat box. Where are the questions?
Doctor, it is there in the
Will
question
be
Q&A
yes,
session.
question answer.
Yeah,
I
it's in the
don't see that.
Q&A.
Please, Dr. Jayesh, can you take them? If you
Yes,
can see them, I can't see it.
So I'm just speaking of first question is that who will be responsible for embryos if both of them die? If the couple nominates any relative, what
Oh,
are
yeah.
they going to do with it? Can they go for surrogacy or is it allowed?
Who is Dr. Mahesh? I think you take this one. Can you take this one?
So
Both.
who will be responsible for embryos if both of them die, Dr. Mahesh? And if the couple nominate any relative, what are they going to do with it? Can they go for surrogacy or is it allowed? Dr. Mahesh?
I don't think he's heard it.
Can I take this?
Yeah,
Yes,
Dr.
yes,
Kalyani,
Dr.
take
Kalyani,
it.
you can take.
Kalyani, you take it. You
Kalyani,
take
you
it.
can take.
Yeah.
So
Take-
as far as the consents and the knowledge goes, there is no option of nomination that, wherein we can nominate that if something happens to both the couples, that it can be given to someone. Again, it falls in the same thing. The third party donation, as of now, it's not allowed wherein, that one couple can donate it to someone else. And for as far as the surrogacy also goes, if you don't have the intended parents, there is no surrogacy, there is no donation, nothing happens if you don't have the intending parents. So there's no rule of nomination out here. There cannot be any nomination like you have in fixed deposit or somewhere that, if something happens to you, that it can be passed on to the next of the kin. So no, this will not be allowed. I think what will it go is indirectly it becomes that there is no intended parents, it will be ultimately be discarded or it could be perished because we don't have the consent for giving it to the another person. There's no as such the consent doesn't exist.
Yeah,
So I
there
think so. As far
are
as concerned,
cases.
you want
Yeah.
to say we want to we are miss it is going to be discard and maybe before discard the author miss organizations can take a consent, right? This is what
Yes.
we usually understand.
Yes.
The
Yes.
second question from Dr. Parul Khanna and what she want to ask: can we take a foreign donor for an international couple? And some couples insist on bringing their own donor.
I think this Mahesh should answer.
No. This is not allowed because as per AIT Act, the person should be Indian origin and they should have an Aadhaar card. So AIT board is the competent authority. So if there is
Yeah.
any deviation, they have to take permission from the AIT board. As such, without Aadhaar, because an international person cannot have an Aadhaar card, so it is not possible for them to be a
But
donor.
are we allowed to take? Are we allowed to do international patients, Dr. Mahesh?
Yes, madam, we can.
I'm quizzing you. We are doing self cycles for international patients. They
Yes.
also don't have Aadhaar card, right? We are checking their identity based on the passports, isn't it? Everywhere that is. So why should there be a separate kind of a pass?
No, we don't
this-
make laws, madam. We follow it.
Yeah, I agree with you. We don't make it's not mentioned, but even international patients are not mentioned in the law. This
Yeah, I
law is
think
only for Indian citizens. It's not for international. So my contention is that if we can use it for one, we can use it for all. But however, as you are rightly saying, I mean, this is a contentious question. As you are rightly saying, yes, Since it is not mentioned in the law, like we mentioned earlier, it is better to take a legal opinion before you go in for this kind of a thing. Definitely. As he's saying, it is not written anywhere and it is not allowed. Please don't be in a hurry to take a foreign donor.
So the third question regarding our fertility freedom, that what we are discussed about the freezing the eggs, and somebody want to know, it's no name is that somebody want to know about the cost comparison. So Kritika, what will be the cost comparison for a oocyte and embryo, and how can you counsel regarding the blastuation rate, maybe a live birth rate, as far as concern the number of the oocytes and depending on the age?
Oocyte survival rate is also a question that has been
Yeah.
asked.
Yeah. Generally, the cost is not higher than the embryo freezing. So you need not worry about it. In fact, the cost is comparatively lesser than an embryo freezing only. So you need not worry about the cost factor. Number two, the blastulation rate in preserved oocyte, it's definitely lesser than a embryo freezing. We cannot have the same.
So the answer is there, if there is a, if the presence of husband is there, and if you have a priority of freeze, the what to freeze, then I think so we will like to counsel them that embryo freezing is better than the egg freezing. But if there is no sperm is available in that condition, yes, definitely the oocyte cryopreservations we will promote. And definitely you say that embryo preservation, the oocyte cryopreservation rate is lesser, the whole treatment costs more. So that the message that we want to do. There is another question is, I think so, it's all about the explanations that I think so. There is not much more questions regarding the part.
Kasturi, can you please explain which last para in the new consent form you are talking about? Can you just write out this question a little more elaborately? And Parul is saying that the ART board in Delhi said that it is allowed. Donor can be routed through an ART bank. That international donor, she's probably saying. The last para in the new consent form asks couple to nominate. I don't have that page now. This is for posthumous reproduction. This is for posthumous reproduction. She's saying that in the last para of the new consent form, we are allowed to nominate. The couple is allowed to nominate the person, and the embryo can be given to them. Is anybody aware of this? I don't know. We are not aware of it, but of course, recently there was a case of a young minor boy who died, and his sperms were posthumously removed and they were given to his parents, and then a surrogate was hired, and there was a pregnancy which happened out of a donor egg and surrogacy with his posthumous sperms. That was a special instance that was allowed in a minor case. But if the gametes or the embryos are there and both of the parents die, then I do not know whether we have consent to nominate anybody and then give it to the next of kin. That I'm not sure of. But we shall definitely ask and get back to you, Dr. Kasturi. We will get back to you on this. We will ask our own legal team and we will get back to you on this. Anything else anybody wants to know? There is another. FAQs. There's another one.
She wants to say that on the national
The
ART
same-
and
same
surrogacy
question.
registry says foreign nationals can, so the same question, can undergo IVF.
Yeah, same.
I think
It's the
we
same.
should come to the end of the session.
Yeah, I think that. Radha, can level 1 ART clinic doctors stimulate patients in their clinics and bring patients to IVF center for OPU? Who's going to take that one? Kritika, you can take it, or someone else. Jasmine, you can take it. Kritika has answered one.
It is actually allowed. The stimulation can be started in a level 1 center, but both the level 1 and the level 2 where pickup is going to happen will have to maintain a record. The file will exist in both the places. The consents will exist in both the places.
Anyone wants to differ in that? The initiation of the cycle, because if the intention is to do an IVF, ART level 1 is not allowed to do an IVF. So if the intent is to do an IVF, hence the stimulation has to be started by a level 2 clinician. The first prescription has to go from the level 2 clinician, and then the stimulation can be done by the level 1 in her own clinic. There is no restriction on that, because the level 1 doctor is also knows how to stimulate, and she can stimulate for an IUI. However, because the intent is to do an IVF and she's not allowed to do an IVF, so you have to basically start the IVF cycle yourself in level 2, and then of course she can take on from there. And of course you're going to do the retrieval and embryo transfer for her, because she cannot do that. She's not allowed.
Okay.
That is very clear. They have mentioned that later on in one of the RTIs.
Ma'am, just saying, suppose in level 1, a doctor has started an IUI cycle in a PCOS patient and the patient hyperstimulates. So she can always transfer that patient to an IVF clinic
Definitely.
for
Yes.
egg collection, right?
Definitely. That is a different situation, Bache. That's not that the intention was to do an IUI. So she started
true.
the cycle. The intention was not an IUI.
Just saying, but
Definitely.
on ground it is the same. That is what I'm saying.
Definitely. Again, we have another one. Can we follow up IUI stimulation scans on teleconsult? I think in India you can do it, but if you're getting one from USA, you can't. What is the next question? Not a stimulation and pickup should be at the same clinic, not allowed. वो तो किसी ने जवाब दे दिया. Could you tell at which article, Radha? What do you want to know, Radha? Which article for what?
Level 1 ART clinic of the stimulation.
I will send you. I will share that. I will share it with you. Please write your email ID over here, or you can give it to us over the phone. I will share it with you. I have it. I think Mr. Selvam, I think we can call it a.
I think so. Yeah.
Yes, doctor.
Yeah, thank you.
Thank you so much, doctors. I think it was an excellent thing, and I'm sure that audience, the kind of a participation and the kind of a questions coming from that, they also thoroughly enjoyed. Thank you all for your active participation and the time, doctor. Thanks a lot.
Thank you very much, all of you. Hope to meet you soon in another such
Thank you
dialogue.
all. Wonderful session, and we enjoyed the discussion. Thank you.
Thank you so
Dr.
much.
Age
Thank
and
you
Dr.
so much.
Sonia. You have put in a lot of efforts, given us great questions. Thank you both of you.
Thank you so much. Thank you, Kritika. You were great as always. All of you, in fact. Thank you so much.
Thank you, doctor.
Thank you. Happy Independence Day. Bye.